Now we know that aortic aneurysm is an increasingly recognized condition, and over the last 3 years the incidence has almost tripled, and this is probably because of increase in age of the population or also in the improvement in diagnostic methods. And it's estimated that more than 35,000 deaths per year are directly attributed to rupture of aortic aneurysm, and it's the 9th leading cause of death in United States. The risk of rupture actually increases with the increase in the diameter of aneurysms. There is a 40 to 50% of these patients would die before receiving any treatment. And once they have a rupture, the risk of perioperative mortality is 50%, and the overall mortality is 75%. So this actually sets the stage that this is one disease which can actually be prevented from growing and also prevented from rupture if you treat the patient in time and diagnose the patient in time. Now, just to go through, there are 3 different types of aortic aneurysms. It could be according to the anatomy in thoracic region. We call it as thoracic aortic aneurysm, abdominal aortic aneurysms, or thoracoabdominal aneurysms. Pathologically, they could be true or false, and anatomically, they can also be saccular, fusiform, or dissecting aneurysms. Now, these are the different types, and they require different types of treatment. A thing to mention here is that pseudoaneurysms of aorta and saccular aneurysms of aorta, irrespective of their size, have the highest risk of rupture, and they should be treated without any delay. Now, there are different etiologies. The most common etiology in our population is atherosclerosis, but it could also be arthritis, Takayasu arthritis, and aortic dissections. The natural history is if you have aneurysms in the thoracic aorta more than 6 centimeter in diameter and abdominal aorta more than 5 centimeter in diameter, the annual risk of rupture is about 20%, and these patients need to be very closely followed up, and they should have surgery or intervention in time. Skip this slide. So, when to treat these aortic aneurysms? If you have in thoracic aortic aneurysm, if you have a size more than 6 centimeter, or in abdominal aneurysm, if you have a size more than 5 centimeter, or if the size is growing by more than 5 millimeter in 6 months, or if the symptoms of compression or impending rupture are there, the patient has to be treated immediately. Now, if you have the risk factors which are common for atherosclerosis, you need to treat these patients very aggressively, especially you have to have the cessation of smoking, and you have to lower the blood pressure and heart rate. The blood pressures have to be kept in a range of 100 to 110 millimeter systolic, and use of beta blockers and ACE inhibitors is very important in these patients. Now, there are different ways we treat. Broadly, they could be surgical or endovascular. Because of the paucity of time, I'm not going to be discussing this, but the major determinants are that for abdominal aortic aneurysm, surgery in a low-risk patient with a long survival, expected survival, surgery has a very good outcome and should be preferred in case the patient is young, and in case the operative mortality is less, and in case the patient has a long, longevity, predicted longevity. But in cases who are in extremes of ages, in patients who have comorbidities, where surgery risk is high, there have been large studies, especially the EVAR, DREAM, and OVER studies, which have clearly proved that endovascular treatment course over surgery has very less mortality and morbidity, and the long, intermediate, and short-term outcomes are as good as surgery, rather they are better. And that is why nowadays the endovascular treatment has replaced surgery in more than 75% of patients. Now, once we know this, why it's very important that endovascular treatment is important. Now, who would be doing it? And the best persons to do this sort of endovascular repair is interventional cardiologists who have acquired skills of vascular surgeon, and also interventional radiologists who can actually read CT scans, plan procedures, and have very good wiring skills. These are the people who can actually treat these aneurysms very well. And all over the world, it's 75% of the cardiologists, interventional cardiologists, who treat this disease by endovascular means. Just to give you an example, this is one of our patients who was airlifted, had thoracic aortic aneurysm, coronary artery disease, and bilateral renal artery disease. And this patient was treated, he had an impending rupture and also an acute coronary syndrome because of hypotension. This patient was treated with a coronary stent, aortic stent graft, and also a renal stent at the same sitting. And this is how we treat our patients. It has become a very common procedure. Dr. Arilan would also be here with me. He does a lot of aneurysms as well. This is our series of 289 patients of TUR and EVAR, and our surgical conversion rate was very low. Only 3 patients required surgery, and that too was in our initial learning curve. We have a mean follow-up of 2 years. The endo leak occurred only in 27 patients and was fixed in 9 patients on the table. We did 11 hybrid and 57 chimney procedures. Now, to do this procedure in a successful way, there are very important steps which have to be followed. First is a proper case selection. As I told you, the patient has to have a good anatomy, have to have a good access site for taking the device, should have a good landing zone and a proximal neck, and should also have a good clinical criteria to actually do the case. So any sacral aneurysm, impending rupture or a contained rupture is an ideal candidate for endovascular treatment. Now before that, appropriate imaging, planning of the procedure, measurement of the neck and the landing zone, measurement of the diameter of the access site, selection of the device, and is very important. And once we deploy the device, graft surveillance is very important, which is done by either an ultrasound or a CT or an MR, is very important. And then we are going to be talking about some recent advances, because this is a progressive disease. Sometimes we have late migration of stents, grafts, or we have late endo leaks, which can be treated and by endovascular means. These are the technical steps which I am going to be skipping. But what is very important is that you should have at least, conventionally, at least a 2 to 2.5 centimeter neck of the aneurysm and a good landing zone of about 1 to 2 inch. And if this is there, then the tortuosity should not be much. The angulation of the aneurysm vis-a-vis the neck should not be more than 45 degrees. And once we have these, we can actually plan the procedure. This is how we make a sizing sheet and a worksheet and select the device and go and plan the procedure, and also have backup options. I'm not going to go through these details, the type of stent grafts, how do we plan and how do we actually choose which graft to use. But what is very important is the vascular access site. The access site has to be at least 7 millimeter in diameter, and if we do not have a proper access site, we have different options. We can endoline and put a covered stent and then crack this vessel and dilate, or we can approach through external iliac or a common iliac route, or we can put a conduit, or even sometimes can go through the subclavian or axillary route. So that's not a big limitation these days. And what is the role of intravascular ultrasound? This is very helpful in patients who have renal dysfunction. It is very important in actually very precise deployment of the stent grafts, and it is also very important to actually look for endo leaks and especially in fenestrated grafts to actually look and cannulate these vessels. Now again, as I told you, the major limitation as of today is the size of the femoral and external iliac arteries, and now we have overcome this challenge, as I told you, by conduits, by opening the vessels, external iliac and the common iliac, and also by endolining and cracking open the vessel. But now also we have devices which are low profile, and nowadays we have profiles of the devices to the size of 14 to 16 French, which are equivalent to the TAVI devices, and most of these patients can be treated. The other challenge was an angulated and short neck. We have now dedicated devices which can actually tackle this short neck by various modification in the devices, and or by actually changing the concept where we actually fill the sac with a non-porous glue, and we actually have 2 non-covered stents which go from the infrarenal neck down to the femoral artery. So what we do is We put in 2 stents, which are like normal stents, and around these stents we fill up the sac with a sac sealing device or a bulb, and this will actually prevent any sort of endoleak. This doesn't require any length of neck. It has very good anchoring. It has very good stability, and there is no risk of migration, endoleak, or we can even work with 0 millimeter neck. So this is how it works. This is one of the new developments of sac sealing in abdominal aortic aneurysm, which has no contraindications and almost 100% long-term guaranteed results. As I told you, just put in 2 stents from neck to the iliacs. Then you blow up the endobags, which will cover the entire lumen of the aneurysm, and leave it like this. The aneurysm is sealed forever, and there is no chance of endoleak or migration. Now, sometimes you have short necks and you do not have this device. So what you can do is to put in staples. These are endo staples, which you can actually staple the proximal neck to the intrarenal neck of the aneurysm and prevent any endoleak. Or if there is a type 1 endoleak, you can fix it by these endo staples. Now, these are the type of incisions which were used for surgery in the past, and the type of incisions which were used to do abdominal aortic aneurysm implants, just little femoral, opening, arteriotomies. But nowadays we do not require any of these things. It is a totally percutaneous procedure, and we put in proglides before the procedure and just tie a suture through a percutaneous route. Now, what are the current trends? The current trends, we had some unconquered territory, especially the ascending aorta, or arch of aorta, where the arch vessels were involved. And now what we do, we can, if you have to treat the aneurysm in the aortic arch, which is involving the carotids or the subclavian arteries or innominate artery, we can do it by redirecting the circulation. We can do a carotid subclavian bypass and then cover the origin of the carotid, left common carotid artery, or we can do a carotid bypass and then can cover the entire innominate artery, or we can do a hybrid procedure where we do a debranching and we take a surgical conduit which will connect to all the arch vessels, and then we can treat the entire ascending aorta through a covered stent. Now, we have even progressed beyond that, and we can actually do something like an endobental, where we have cerebral protection devices which can actually prevent peri-procedural embolization. We do a TAVI, and we do chimney grafts to the coronaries and putting aortic standard graft. So this percutaneous bental has been done in humans as well. One case has been reported from South America, and this is the future of endovascular repair in complicated abdominal and thoracic aneurysms. A new concept has come where you don't have to cover any of these arch vessels. Even if you have to cover, you don't have to worry. You don't have to do a hybrid. You don't have to do chimney grafts. You could do something which is known as multi-layer flow modulator, which actually modulates and redirects and centralizes the flow through the center of the lumen and prevents the eddy currents from forming, and actually makes the aneurysm shrink over this non-covered stent graft. And this can be used right from ascending aorta, covering the coronaries, to aortic arch vessels, to mesenteric vessels and renal vessels, and sometimes you can even cover it with TAVI. Now, this is our first case which we had done. This is a 9-month follow-up of covering the aortic aneurysm with a multi-layer flow modulator, and you can see all the arch vessels are patent, and there is a remodulation and remodeling of the aneurysm over these stent grafts. This is the similar case covering the mesenteric vessels in abdominal aortic and thoracoabdominal aorta, which works very well. And we are now going beyond this to genetic manipulation. We have a gene identified for the expansion of abdominal aortic aneurysm. This is the LRP1 gene. And we can actually work on epigenetics and down-regulate the expression of this gene and prevent this aneurysm from expanding if we diagnose early, and actually prevent them from rupturing, expanding, or needing treatment in form of endovascular repair or surgical treatment. And robots have also come in play. Now the procedure can be done with a lot of precision with the help of robotics. This is one of the cases done by endovascular aortic repair done by a robot, and this is the new thing which is going to come in our center, and probably we'll be using it very soon. And I'm going to skip aortic dissection, which is also a part of the dissecting aneurysm, but just to end here, if you have a patient of aortic dissection, if you have an acute dissection, you should treat it by endovascular or surgical means. If the patient sort of, is stable for 1 month, the natural history of this patient will be same as the natural history of undissected aorta. But you need to do a surveillance, and if you find that the false lumen is expanding, you actually then go and electively intervene by endovascular means. The second point where you have acute ischemia of the mesenteric vessels, which could be carotid, mesenteric or limb vessels. In those sort of situations, what is required is not sealing of the entry point, but what is required is the fenestration, which we do percutaneously, and we fenestrate and create a connection between true and false lumen to relieve patients of renal failure, mesenteric ischemia or limb ischemia, and that is what is done in these sort of patients. Now overall, I'll just end here, endovascular medicine and peripheral arterial disease. This is something which is growing. It's estimated that there will be a 78% increase in endovascular procedures, and that will be the biggest driving force of interventional cardiology in the coming decade. And this is the data which we collected from our NIC registry of about 72,567 procedures have been done, and there are about 659 centers which have actually started doing endovascular procedures, not aortic aneurysm, but peripheral endovascular procedures. And these are the centers which can actually take up this endovascular aortic work also. This is my personal series of 289 patients, and you see there is a very little chance of complication. And based on this, we have extended and started teaching courses and all over the Southeast Asia, and this is the course which we conduct, the Asia Pacific Vascular Interventional course, and on-site, on-the-site teaching course under the aegis of APVIC in different countries of Southeast Asia and also different centers in Asia. And we would invite all of you to this course in May. We actually do it in the last weekend of June, but this time because of the shifting of the dates of NIC meeting, we are doing it in May, and I invite all of you for this workshops, which includes the endovascular aortic aneurysm repair workshop. This has been the growth of our meeting in the last decade, where you see more and more centers and international collaborations have been done with our society and the meeting, and this would lead to a proper guidelines to actually diagnose this disease, which is very important to actually identify this disease early to prevent ruptures and also to prevent endovascular need for endovascular repair and surgery in these patients. So thank you very much, and if there's any question, I'll be happy to answer.